Hi, good evening, everyone. This is Dr. Krishna, founder and chairman trustee of Chest Council of India. Well, this webinar is different from the other webinars conducted on the during the WAD month. So I'll use this terminology, WAD month, not World Asthma Day. So this entire May will be observed for different World Asthma Day events. So during the World Asthma Day month, we thought of picking up this webinar. So the header of which is, what is the significance and importance in observing World Asthma Day, an initiative of GINA? So for this particular topic, before I would introduce you my team, I would like to tell you, this is very important that why you observe a particular day for an illness. Something like you have heard of World Asthma Day, World Cancer Day, and all that. So why is that? Is it something like related with you call as Children's Day, Teachers Day? Is it something like that? Yes, it is so. Why? Because on that particular day, that day will be dedicated for this particular affair in the media and people related to it, in the sense those medical doctors, the paramedical staff, the patients, they are all involved in this particular, on this particular day, observing this day, doing activities related to this event. So that is how that will have an importance in broadcasting awareness to the common public related to the illness. On that day, articles related to the illness are written and published regarding the illness. And camps and demos take place on the occasion of World Asthma Day, and via which spirometer, lung function test, or inhalation technique demonstration are all held across. So common public come to know what is uncommon to them regarding an approach via a pulmonology way of thinking towards the bronchial asthma. It will make people to be aware of the possible allergy and asthma they are their near ones may already have. So they will get a hint, a clue that if these symptoms I have, could I have this, or am I already having something like allergic, or am I asthmatic, something like that. So, and also this educates for preventive measures like environmental cleanliness, social responsibility of every citizen towards the Mother Earth. Again, I want to quote it here, observing something like a Sri Krishna Janmashtami or Sri Ramanavami, even for Eid Milad, Christmas, Guru Nanak Jayanti, Gandhi Jayanti. So why they are observed? Because it attracts the public to observe the preaching and good deeds, at least on that particular day related to this. So when this can happen, it is very similar that we can make it happen on during the Krishna World Asthma Day, the awareness could be given. Well, I'm very happy to announce that 1,467 pre-webinar registrations are already there. We are expecting a very good number here. And it is not because that I am present here. Whenever Raja arrives, you get a very good number of logins. Let me introduce my panel to you. So I would like to introduce you all to my very good friend and who doesn't need any introduction, who is the moderator for today. And also, he will be giving a presentation today, live presentation regarding this topic. He's none other than Dr. Raja Dhar from Kolkata. It's my favorite person. I always hide myself behind the screen. I never come to the webinars. So behind the screen is my business. But he always pulls me and he makes me to come to his webinars. So thank you for that attachment. Thank you so much. So let me introduce you to the rest of the panelists. I will start with the respected, charming Dr. Radha Munje, who is from Nagpur. She has always been our CCI's, whenever CCI wanted her, she has always been our at rescue. Whenever we need a panelist, whenever we need ma'am, she always appeared. And you don't go on that my name is Krishna and ma'am name is Radha. So Dr. Shivani, she's from Jaipur. Dr. Shivani is a pulmonologist, very popular there in Jaipur. She is our one more panelist today. We have Dr. Asuri Vinay Kumar from Karimnagar, who is our panelist. I have Dr. Kripesh Ranjan Sarmah from Guwahati, who is our panelist. The descriptive panelist introduction will be given by Ravi Dosi. So, and we also have Dr. Ravi Dosi here from Indore, who is CCI's, what I tell you, cutthroat fan. He will be always there whenever CCI needs him. And today, before I leave, I would like to quote that thanks are very less when it comes to the matter of thanking Dr. Narayan Pradeep, the co-founder of CCI and the chairman. And I would also like to thank today's this year, academic years, our President, Dr. Ashish Dubey, and our Secretary, Dr. Anil Maske. And thank you so much, Dr. Asuri, for conducting these webinars. You are the spearhead, and you, whenever I need to tell anything regarding the topic, it flashes my mind. I only have to communicate to one person, and he does everything else. So thank you very much, everyone. Ravi will have the introduction of the panelists now in a descriptive way, then Raja Bhai presentation. Raja Bhai, up to you.
Very good evening. Very good evening to all of you. Thank you, Krishna sir, for your presence and sparing time for us, sir. Just before, I know everybody, the whole of India and the whole of chess fraternity is waiting badly for Raja Dhar sir to talk about GINA 2023. But a big thank you, Krishna sir, for sparing today. I believe you had a family function, then too you could come. Thank you. I would like to introduce our respected and distinguished panel of the faculties today. We have Dr. Raja Dhar sir, who is HOD and Director, Department of Pulmonology, CK Birla Group of Hospitals from Kolkata. We have respected Dr. Radha Munje ma'am, who is Professor and HOD, Department of Respiratory Medicine, Indira Gandhi Medical College, Nagpur. Now, madam is also Medical Superintendent of IGGMC and Mayo Hospital. And really, ma'am, hats off to you. And then we have Dr. Shivani Sharma with us. She is Head of the Department of Pulmonology, Allergy and Sleep Disorders at Narayana Multi-Specialty Hospital, Jaipur. We have Dr. A. Vinay Kumar with us, who is Professor and HOD, Department of Pulmonary Medicine at KIMS, Karimnagar, Telangana, and he's a consultant pulmonologist at Surya Chest Hospital. We have Dr. Kripesh Ranjan Sarmah, who is a senior consultant and the head of the department at Department of Pulmonary Medicine, Apollo Hospital, Guwahati. And you have me truly, who is from Indore. I am a consultant pulmonologist at Kokila Ben Dhirubhai Ambani Hospital. Now, over to you, Raja Dhar sir. Can't keep people waiting more.
Thank you so much, Ravi. Thank you for those kind introductions, and a special vote of thanks to Krishna Bhai. As he said, he makes it a point to come to every meeting that I moderate. So I'm very grateful, and I got a wonderful panel. And we'll come to all of you with questions. The aim is to do a 20-minute presentation where I'll point out the relevant changes that have happened in GINA. And I'll do that slowly. I'll try to give it an Indian perspective. And then we'll come back and discuss some more points going forward about GINA 2023 with a special focus on how it is related to the Indian perspective. That's what we are going to do till 9:30 today. So I'll just share my screen. Give me one moment. So I need to thank the GINA board, especially G. Brussels, who's actually given me these slides. The GINA slides are teaching slides which are normally available freely, but because the GINA guidelines are as new as they are, these are not up on the website as yet. So the slides I'm sharing, you will all get them on the website in about 10 days time. But as of now, they are not available on the GINA website. So Krishna Bhai laid the background very nicely. He talked about the World Asthma Month, the World Asthma Week, the World Asthma Day, and the significance of this. There's GINA, which has started off with World Asthma Day. And then there's the 2023 guidelines, which I'm going to talk about. Before I do that, let me give you a little bit of background about the history of GINA. So we start the journey about asthma from about 1970s, 1980s. This was the time, very relevant today, the time when bronchodilation was thought to be the cornerstone, the backbone for the management of asthma. And it was only short-acting beta agonists, it was bronchodilators, which formed the treatment of asthma. So this was the time, and I'll show you a slide in a minute, where there was increased prevalence of asthma deaths, and the number of asthma deaths shot through the roof. And it was thought to be one of the biggest public health problems in the 1970s and 80s. As a response to this, in between 1980s and 90s, some countries like Australia, New Zealand, Canada, and UK published the first asthma guidelines. And this happened between 1980s and 1990s. Interestingly, New Zealand was the first country which did this, then Canada, then Australia, and then the UK. And we had the first BTS guidelines for asthma as early as the late 1980s. 1988 is when the first guidance came out. And then you had a sea change which was driven by the National Heart Lung Blood Institute, the NHLBI, which started a project which was called the NAEPP. So the National Asthma Education and Prevention Program. That's what the acronym stands for. There's still a very active NAEPP body. So I want you to remember that acronym, National Asthma Education and Prevention Body Program. This was an expert panel which started reporting on the diagnosis of and management of asthma. And then the World Health Organization and the NAEPP, the arm of NHLBI, prepared the first international consensus report on the diagnosis and management of asthma. So this took about 2 years' time. And in 1993, the steering committee for GINA was formed. So you understand, we are talking exactly 30 years ago, 2023, 1993. So we're talking 30 years ago. The first GINA report for asthma prevention and management came out in the form of, like we said, the NAEPP, the NHLBI arm for asthma, and a WHO workshop, which happened in Switzerland, in Geneva, in 1995. And you had a report immediately after that. And the people presiding this meeting are phenomenons in asthma, not because they were great doctors who managed asthma. I'm sure they were. But the more important part was the thinking that international guidelines were possible, were important, was actually something which changed the course of asthma in the next 25 years that we're going to talk about today. So Claude Elephant, Suzanne Hurd, the scientific director, formed the first concept of GINA guidance for asthma. Major revisions have happened over a period of time. The new guidelines from 1995 were published again in 2002, 6, 14, and 19. And now things have changed and you have annual guidelines. So the guidelines now revised annually. To be honest, there was time in 2021 when we had 2 guidelines come out in 1 year. One might argue that this was too frequent, but then again, the treatment of asthma, the thinking about management of asthma is undergoing a sea change as we speak. And we will focus on certain of these exciting ideas, exciting areas as we go along. You now have a pocket book for asthma management, and there's lots of our colleagues, our friends in CCI, who I'm sure would benefit from using this pocket guide for asthma management and prevention. There's the GINA teaching slide set, which will include the slides that I'm showing you just now. There's the implementation toolbox, patient guide on asthma control, and videos and podcasts. So that's about GINA, a little bit of history about GINA. Let's now talk a little bit about World Asthma Day. You heard from Dr. Krishna about why it's important to celebrate a day. And to summarize what he said, it's important to celebrate a day because it raises awareness about a disease process. And a disease process as important as asthma, especially in Indian perspective, is very, very important to remember. And you remember this both in terms of prevention and in the terms of management. We all know asthma is not a disease that can be cured. It is something which can be controlled. However, we also know that unlike a lot of other chronic diseases, asthma control often translates it's into perfect control. And you have these celebrities like Amitabh Bachchan, Saurav Ganguly, the US presidents. It's often joked that you cannot become a US president unless you have asthma. That's how common asthma is amongst the US presidents by some peculiar twerk of fate. So asthma cannot be cured, but you can actually manage asthma to an extent that you can lead a normal life. And that's why quoting the names of these celebrities who've made it to the very top is so very important. World Asthma Day is one of the world's most important asthma awareness and education events. And you heard from Dr. Krishna as to what some of these events entail. A lot of us on the panel, a lot of us who are listening in would have actually done events to improve the image of this disease, to improve the awareness of this disease, to try and inculcate the protocols and guidelines that we're going to talk about amongst doctors and patients. The World Asthma Day, interestingly, the day, we spoke about the month, but the day is the first Tuesday in May. There's a theme every year, and I'll show you the theme this year, which is particularly relevant to countries like India. But each year there's a theme. There are preparations and distributions of World Asthma Day material, and big international bodies like GINA, the European Respiratory Society, etc., circulate these resources throughout the world, and we make our own. So there's a lot of our friends, I'm sure, on this platform today who've circulated their own material in trying to educate people about asthma in the local language, in our own language. The first World Asthma Day is interestingly 25 years ago. So 2023, celebrating the 25th year of the first World Asthma Day, which was held in 1998. It was celebrated at the time in 35 countries. It's celebrated in more than 100 countries today. The first World Asthma meeting was, I said, by mistake, Geneva. It was actually in Barcelona in Spain. That's where the first World Asthma meeting was held. That's the logo, that's the slogan for World Asthma Day. And why is it relevant to us? I said it's relevant to India. Why is it relevant to us? So World Asthma Care for All is the logo, it's the slogan for World Asthma Day, the 30th global GINA initiative that we have. The reason it's important is that it highlights the fact that 80% of the morbidity and mortality of asthma comes from low and middle income countries. A lot of the guidelines that have come out from GINA in the past have focused on the developed country rather than the developing countries. And this is the welcome shift in focus, where people are talking about ensuring availability and access of effective quality medications throughout the world. And the Asthma Care for All message promotes the development and implementation of effective asthma management programs in countries, irrespective of what their resource status is. And like I said, that's the first big paradigm change in thinking about World Asthma Days since its inception 25 years ago. The burden of asthma is huge, and I won't quote you lots of numbers. That's not the prerogative of the meeting today, but it's the most common chronic disease worldwide. You can see the mind-boggling numbers there, 358.2 million affected individuals, according to the last global burden of disease data. This significant morbidity worldwide. There's estimated 38 million asthma patients in India. This is a great slide. I don't know how well it projects on your laptop, but look closely. You see the era that we spoke about between the 1960s and the late 1980s. So sort of between 1960 and 1986. And you can see the waxing and waning, the very high mortality that you get from asthma during the set period. This was the time, like I said, when you focused on bronchodilation rather than anti-inflammatory therapy for the management of asthma. And our understanding, our thinking about asthma being managed with anti-inflammatory stemmed from our failure to manage asthma with bronchodilation between the 1960s and the late 1980s. As soon as we realized that inflammation is the crucial factor, inhaled corticosteroids is the most important factor in the management of asthma, you can see a paradigm change. You can see the number of deaths from asthma come down drastically. This is a paper that was published by my good friend Ian Pavard's group in 2017, and the numbers are from 2012, but you would see the number of mortality from asthma has gradually come down as anti-inflammatory treatment has gradually become more and more popular in asthma throughout the world. So what are the risks of mild asthma? So the perception is, if you have moderate or severe asthma, so if you've got GINA 3 and beyond, that's a risk. Mild asthma, little amount of symptom burden, no one bothers about it. Is that the right approach? In a lot of diseases, mild disease does not really appear worrisome. However, asthma is not like that. And the reason are the numbers on that slide in front of you. So in patients with mild asthma, there's still a significant risk of serious adverse events. So 30 to 37% of adults with mild asthma will have acute asthma. 16%. So that's 1 in 6. It's not a small number. So 1 in 6 patients will have a near fatal asthma, and 1 out of 5 or 1 out of 6 patients might die of an attack in mild asthma. So mild asthma does not necessarily mean that it's not exacerbation prone. It does not mean it will not result in hospitalization. And that's why the risk of mild asthma is huge. How do we define mild asthma today? And that's one of the challenges. Mild asthma is defined not based on symptoms, but the amount of medication that you use. Mind my words. So it's not dependent on how much symptom burden you have, but on the intensity of treatment. So low dose inhaled corticosteroid along with formoterol or a low dose of ICS plus an as needed SABA forms the basis of management of asthma. So why is that a challenge? Now, if you're trying to go by the GINA ladder, which is mainly based on symptoms, you would always treat your patients with mild asthma with an ICS formoterol on an SOS basis, the so-called MART therapy, the maintenance and reliever therapy, which I'll come back to when we do the panel discussion. However, if your patient exacerbates recurrently, and we've shown the numbers as to exacerbation in this slide, you understand that you need to go up the escalator and try and make sure you prevent exacerbations, which is one of the most important targets, one of the most important endpoints in the management of asthma. The exacerbation triggers are common, be it mild, moderate, or severe asthma. They are unpredictable. So you've got viruses, pollens, pollution in our country, biomass exposure. All of these are triggers for asthma. Inhaled short-acting beta agonists have been the backbone of management of asthma for the last 50 years. This was the time when we said asthma was thought to be a disease of bronchoconstriction. The treatment is low cost. Patients get a huge benefit. And hence, the patients who are on SABA, even today, your patients and mine, are difficult to get off the SABA because they get this relief when they use their short-acting bronchodilators. However, the short-acting bronchodilators we now know have a huge risk. Even using for a 1 to 2 week period increases the risk of exacerbations and worsens control in the long term. There are adverse clinical outcome with frequent use. So what is frequent use? Frequent use in terms of more than 3 canisters per year. So more than 3 canisters per year, which is not a large number, is associated with a higher risk of severe exacerbations. And if you're using 1 a month, so 12 or more canisters per year, then there's a high risk of mortality. So 3 or more canisters in a year, you have a high risk of exacerbations. 12 or more canisters in a year, you have the risk of death. And inhaled corticosteroid, which is, as we know, is the most potent anti-inflammatory we have, will reduce asthma deaths, will reduce hospitalizations, exacerbations, and the requirement for oral corticosteroids, which, as all of you know, have a lot of perceived ill effects, detrimental effects to patients. So why not treat with the SABA alone? So this was a question that got answered with the GINA guidelines of 2019. And for the youngsters in the audience, this got answered on the basis of 2 papers, which have now famously been called the Sigma 1 and the Sigma 2 papers. So 2 papers, Sigma 1 and Sigma 2, which got published in 2018, and the 2019 guidelines had the biggest change ever since the inception of the GINA guidelines in 1995. So we have said that mild asthma can still have fatal or severe exacerbations, and even 4 to 5 courses of oral steroids throughout one's lifetime. So 4 to 5 courses of oral corticosteroids in one's lifetime increases the risk of osteoporosis, diabetes, and cataract. If you use inhaled bronchodilators, short-acting beta agonists for even up to 1 to 2 weeks, your airway hyperresponsiveness increases, you have reduced bronchodilator effect, you have increased allergic response, and you have increased eosinophils. Starting treatment with SABA trains the patient to treat their asthma as short-acting beta agonists being their primary treatment. I said that in a complicated way. Let me simplify what I said. So if you think about previous GINA guidelines before 2019, your step 1 and step 2 used to be a SABA. So you give patient a SABA, ask them to use it as and when required. The patient thinks this is my main treatment. They forget about the anti-inflammatory when it's introduced. The SABA gives them relief, and they stay on the SABA even when you have prescribed the inhaled corticosteroid. Hence, the importance of the 2019 guidelines when GINA said change to inhalers which will always have an inhaled corticosteroid in it. So irrespective of what you take, every puff of inhaler, be that maintenance or rescue, should have inhaled corticosteroids within it. So regular use of ICS results in decreased risk of deaths due to asthma. And this is a lovely paper from Swiss, which came out more than 20 years ago, mind it, which showed that the number of canisters of inhaled corticosteroid was directly proportional to the reduction of deaths in asthma. So we knew that 20 years ago, but it took us 20 more years before the concept of inhaled corticosteroid with every puff of inhaler came into being. This is what I was talking about a little while ago, the goals of asthma management. There are 5 goals on there. And I want you to remember all of them, but especially the ones in red. We're trying to do 2 things here. We're trying to reduce asthma exacerbations or prevent asthma exacerbations, and we're trying to prevent asthma mortality. We are trying to control symptoms. We are trying to maintain normal activity. But one would argue that there's been too much of focus on trying to control symptoms, which is what has promoted bronchodilation as the chief management. And if you think about exacerbation reduction, mortality reduction, the focus comes back on inhaled corticosteroids. We all know that ICS and LABA complement each other. And there's a list of LABA there in front of you. I've just given some random examples: formoterol, salmeterol, the more young cousin vilantrol, and there's a list of inhaled corticosteroid, and there could be many more, but I've talked about beclomethasone, budesonide, fluticasone, and mometasone. And I hope you can see my cursor on a portion of the slide on a cartoon which you've seen all before. So the corticosteroid receptor and the beta-2 agonist receptor feed into each other. They promote each other's action so that the effect becomes synergistic rather just than being additive. So it's synergistic effect. One promotes the activity of the other, which is why giving the ICS and the LABA together makes such a lot of sense. So this is the GINA 2023 algorithm that all of you must have seen or should have seen. This talks about anti-inflammatory reliever therapy. I'll say that again because this is a crucial term, and we'll come back to this in the panel discussion again. So we're talking about reliever. We're talking about anti-inflammatory reliever. So when we talk about anti-inflammatory reliever, it almost always points to the fact that there's an inhaled corticosteroid in the reliever. So AIR, air, anti-inflammatory reliever can be of 2 types. It can be a LABA and an ICS, or it can be a SABA and an ICS. And those are the 2 tracks you can see there highlighted for you. So in track 1, you have as needed low dose ICS formoterol, and in track 2, you have as and when needed ICS and SABA. And it's important to remember that when you give a reliever now, it should contain an ICS along with it. So anti-inflammatory reliever of air is a new term that's been promoted and proposed in the GINA guidance, which I believe all of us should use. Now, this is as and when needed ICS and SABA. This is based on a small trial, but a robust one that got published in the New England Journal about 2 years ago, which looked at salbutamol and budesonide. So it's a US study, talks about albuterol, same as salbutamol. So salbutamol, budesonide, fixed dose rescue combination as rescue inhaler for asthma. And this shows that the combination causes a reduction of severe exacerbations compared to a SABA alone. So the comparison with a SABA alone and ICS plus a SABA reduces exacerbations significantly, which is why track 2 gives you the option of using an ICS and a SABA. There are various terminologies, and I want all of you to look at this table. So this is box 3.4 in GINA. I want you to remember that. I want you to go to the GINA guideline, the actual written version online, and look at these terminologies that I'll talk about very briefly here for the want of time. So maintenance therapy is treatment that you take every day for asthma. So that's maintenance therapy. That's not changed. It remains the same. That's maintenance. Then you have controller. So controller therapy is medication which targets reduction of symptoms and reduction of future risk of exacerbation. That again is not changed. So controller medication is reduction of symptoms or prevention of symptoms and prevention of future risk. Then comes reliever. So any inhaler that you take, including a SABA, which gives you quick relief, is a reliever. So maintenance, controller, reliever are terms we've used before. But then comes the anti-inflammatory reliever, the AIR I spoke about. This is an ICS plus a SABA or an ICS plus a LABA. And then you've got a term which has been there for a few months, well, a few years now. That's maintenance and reliever therapy, which is the ICS formoterol combination, where you use the same inhaler, both for maintenance and for reliever therapy. Despite the addition of ICS and SABA, and I showed you some evidence as to why it should be used, track 1 remains the preferred track as compared to track 2. And that's for multiple reasons. And I want you to remember these reasons because they're relevant to your clinical practice. The simplicity of the approach for patients and clinicians, it's a single drug. You don't have to use 2 different inhalers. It's the same inhaler. You can step up and step down and change doses based on that one inhaler. And the fact that when using an asthma action plan and the symptoms get worse, you just escalate the number of puffs of the inhaler you have in trying to control symptoms. So it's an all-in-one rule which helps you in treating asthma. And that's why track 1 remains the preferred option. Also, the fact that formoterol is more effective in relieving exacerbations, improving bronchodilation as compared to a SABA. And this is based on robust data, 30,000 patients on a meta-analysis and an RCT with 3,000 odd patients with as and when needed ICS and SABA. And they found that formoterol, the LABA, worked better in increasing bronchodilation and reducing symptoms as compared to the SABA. And the availability of this medication is widespread. As and when needed ICS formoterol in mild asthma, this is another study which I spoke about a little while ago, the Sigma studies from 2018, which compared ICS formoterol with as needed SABA. And you've heard this before, you should have heard this before, the fact that the ICS formoterol arm, the formoterol budesonide arm, caused a 64% reduction, which is a very large reduction in exacerbations compared to the SABA arm. And it was not just compared with the ICS LABA compared with the SABA. Even when you compared it with the ICS and the SABA, you had better results. So maintenance versus SOS, you had reasonably similar results. ICS SABA versus ICS LABA, you had reasonable results. Compared to the SABA, it was hugely better. This is the meta-analysis of 4 RCTs with about 9,500 patients, which looks at as and needed ICS formoterol in mild asthma. This is new in the guidance from this year, and it shows a 55% reduction in severe exacerbations, similar risk of severe exacerbations as daily ICS plus as needed SABA, reduction of hospitalization, reduction of use of SABA, etc. So on all of these parameters, the ICS formoterol as MART therapy scores over other forms of therapy. This is GINA highlighting again the importance of an action plan, and we'll discuss this during the panel. Remember this yellow, the orange, and the blue, the red box. The red being your asthma emergency, the orange being an asthma flare-up, the yellow being the normal mode of asthma. This has been modified to an extent, but I promise we'll come back to this when we do the panel discussion. These are the recommendations in children, which also talks about MART therapy in children for the first time. None of us on the panel are pediatricians, but Dr. Dosi has volunteered to speak about the GINA 2023 recommendations for children and we will have a discussion with him as we go forward in the panel. So, in the management of severe asthma, there's been a few changes. There's a new drug that's been mentioned in childhood asthma, which is mepolizumab, licensed for adults, but now licensed for 6 years and above. We need head-to-head studies between these various biologics. Another last important point that I want to emphasize before I go to the panel, and I have run over by about 3 minutes, is environmental consideration. I think this is a brilliant new addition in the GINA guidance. We keep talking about which medications suits the patient. What are the inhalers available to the patients? Can the patient use the prescribed inhalers properly? But what we don't discuss is the question, the fourth question there, which inhaler has the lowest environmental impact? And this lotus that GINA has given us this time, the 4 arms, the questions that you can see at the top for these medications, which inhalers are currently available to the patient? The second petal says which of these inhalers can the patient use correctly after training. The third petal says follow-up of the patient's satisfaction with medications and inhalers. And the fourth one, which we'll discuss in the panel, is which of these inhalers has the lowest environmental impact. And you as a physician, us as a physician, need to think about the environmental impact of inhalers, what has less impact on the environment. All of you know about global warming and the challenges that we are facing throughout the globe, including India today. So I'll stop sharing there. And if I can request everyone to put on their videos, we'll start off with the panel. You've got about 50 minutes for the panel. Wonderful. So I can see everyone. Let's start off with just getting myself into gallery view. Yeah. So let's start off with the panel of questions. You've been introduced to our wonderful galaxy of stars by Dr. Ravi Dosi already. So without wasting time, let me come to my first question. And let me start off with you, Shivani. So 2019, GINA committee has repetitively said that we should use an ICS formoterol with MART for most of the steps of GINA. When I say most, I exclude step 5. But even in step 5, there's a role for ICS formoterol therapy. So I wanted to find out from you first, so the western part of the country, and then I'll go to the east. I'll ask Kripesh. But how much has this translated into practice, your own practice, for people around you, the people you see in Rajasthan, in the western part of the country? How much has really this translated into practice? Or do you still see a lot of people who are on the conventional ICS formoterol for maintenance, but taking a SABA as rescue? Shivani first. Shivani, you have to unmute yourself. We can't hear you as yet.
Yeah, I'm not very techno-savvy still, it seems. Good evening, everybody. And I'm very happy and glad to be here. So answering your question, Dr. Raja. So I guess when it comes to practice of specialists or people who are reading GINA, and especially pulmonologists, I think it has pretty much translated into practice that all of us, I would like to believe, have moved to the SMART or the MART therapy. However, when we look at the wider picture, like you rightly said, that a lot of people still go to the periphery. The first presentation is to either a GP or a doctor in the periphery, and they're still very fond of starting SABA, or at best maybe a ICS combination with the SABA. And at times, by the time the patient comes to us, it really becomes difficult to convince them to, change their at least reliever inhaler to the same inhaler that they usually take for maintenance, or, the anti-inflammatory medicine that we like to call it now. So I think that becomes a challenge. However, still the pulmonologists at least have moved to MART therapy, which is also a big achievement.
Sure. No, it is, Shivani. I mean, not long ago, we were talking about salbutamol tablets. It's still a challenge. At least we have moved away from tablets and we are talking about doing away with the inhaler. I mean, we spend such a lot of time in trying to convince people that they should take an inhaler. Now we're going to the next step, which is to say, don't take your salbutamol inhaler, take an inhaled corticosteroid. I'll take that same question to you, Kripesh. Kripesh, you and I practiced in the eastern part of the country, and I'm not sure all pulmonologists in our part of the country, at least, are still going with MART therapy. I think there's a lot of salbutamol around even now.
Yes.
Yeah, yes, yes, sir. Till there are still many people use salbutamol as a SOS basis because they are using it, and it has become a little heavy for the doctor also and for the patient also to get a salbutamol inhaler for the rapid relief. So even if they are using this ICS formatal combination, many times I have seen the patient prefer to have a salbutamol as a SOS. And also many prescription doctor write also salbutamol as a SOS compared to a smart therapy.
Yeah, Kripesh. So fair point, absolutely. Am I audible to you? It says my connection is unstable. Can people hear me still?
Yes,
I can see Ravi nodding his head, so I must be. Yes, I'm audible. Okay. So Kripesh, fair point. I think you and Shivani both made one point which is important, and this is for the audience, a message. If you have someone who is already on a salbutamol inhaler, it's actually a huge challenge to try and take all inhaler. That's difficult for people to do that, and it's important to preach the So I'm sorry, I don't know where you lost me. Was I audible till the end? I'll ask Ravi. Ravi, was I audible till the end, or did you lose me somewhere in between?
Some 10-15 seconds gap, sir. We lost you at the end.
I was just giving a message, so I'll repeat that and then I'll come to you, Ravi. So my message is, if you have a patient who is on a salbutamol inhaler, it's actually a challenge to get that patient off and try and spend some time in explaining the adverse effects that the salbutamol inhaler can have in the long run that we spoke about in the talk today, and we'll keep repeating through the length of this talk. Very important, no short-acting beta agonist in patients with asthma. Let me come to first to Ravi and then to Vinay. Ravi, to you first. Are there patient profiles which in your mind you tick when you think this is my patient who will have track 1 and this is my patient who will go on to track 2? Or is it all patients across the board on track 1 for you just now? Ravi.
Well, as far as I am seeing it, sir, if formoterol combination is available in the market, then track 1 is absolute best. Only in a condition where formoterol is not available will track 2, I feel, is to be considered. Or suppose if there is a patient who is already very much stable, having good adherence and no exacerbation with his current therapy of whatever he is taking except the formoterol one, then only I'll continue on track 2. Otherwise, I would like to take universally everybody on track 1. Sir.
Yeah, wonderful. I like your answer, Ravi. I'll come back to your answer in a moment, but I'll get Vinay ji. It's good to see you, Vinay. Long time.
Nice.
Hope you're doing well.
Yes,
so same question for you, Vinay. Always track 1, or would you often do track 2, or at least some of your patients you would do track 2?
So these days, very rarely, sir, because very old patients who are carrying salbutamol, rarely I've seen these days. But if they are carrying salbutamol, I always advocate them. This LABA plus ICS only, but unless right now it is widely available at our places, I see there is no hindrance for the LABA ICS combination. And very old patients and very rural area patients I see of quite rarely, but I motivate them, and I think now it is very much acceptable for them, this LABA as well as ICS combination. But those who are not willing, those who want to carry with their old medication, like Aerocod, what is there in the market, I still advocate them to use, but with caution, and advocating them and giving them, especially with their warning symptoms, I ask them to come back to the hospital. That's how I'm managing.
Yeah, wonderful. So very good points. So points that were made, I think the first point for the audience is, if you've got someone who's very stable, hardly uses the salbutamol inhaler, but has a dependence on the salbutamol inhaler, I would actually hesitate to take it away from them in my practice. So I would say If you're happy, if you're hardly using the salbutamol, you're fine on your ICS LABA, please continue on the ICS LABA, but come back to me if you find that you're using too much of your rescue salbutamol. Don't take that away from the patient, I think, if the patient has reliance on it, because that lack of confidence actually changes your mindset and makes you feel mentally weak from an asthma perspective. That's one. The second point, and maybe Ravi, a quick comment, I'll come back to sort of pediatric asthma later on with my limited understanding, but children, I actually don't change the salbutamol. I don't think there's enough evidence just now to change the salbutamol inhaler to MARD therapy. We've got emerging evidence from GINA in 2023. That's little amount of evidence, and I haven't really changed my practice for the small number of pediatric patients that I see in my clinical practice. The third, I think it is elderly people. Elderly people have a fixed mindset, and there too, I wouldn't actually take their SABA away, because the other thing is when you use your spacer and you put 10 puffs of your salbutamol into the spacer during an exacerbation and you breathe in and out of the spacer, I don't think there's enough evidence as yet to say that in an exacerbation, the same with your ICS formoterol would have a similar effect. So that's another territory where I think SABA will still have a space. So in the asthma area, I think like the cigarette packets, you would probably put a caution on the label to say, please handle with care. Please make sure that this has adverse health effects. But I would still keep the SABA. I wouldn't do away with the SABA at the moment, but there should be a statutory warning. And I'm not joking. I think there should be a statutory warning on the SABA for patients with asthma. With that, let me come to you, Radha Didi. Good to see you as always. Didi, about devices. I wanted to ask you about devices. I wanted to find out, what do you think about, so we're talking in the perspective of GINA, we are talking in the perspective mainly of ICS formoterol. Do you think the device matters when you're giving it to your patient, especially with MARD therapy? Would you prefer the MDI or the DPI in this particular scenario? Or do you think it's the patient's choice at the end of the day?
Yes. We all know, and I think I'm sure we have all discussed it amongst ourselves. The device should be chosen with looking at the patient's, his requirement, affordability, and whether he understands your instructions. I'm sure Raja, as well as all my fellow panelists, have gone through a number of papers which comment upon the MDI being not taken in a proper way, not all steps being followed, and hence your asthmatic patient continues to be uncontrolled. In fact, that is the first warning we talk about when we talk about difficult asthma, right? So I feel that absolutely. the devices should be chosen very wisely. And even if we are talking about asthma and we are not talking about COPD right now, I would say that all your old patients of asthma, you should keep a watch on their spirometry and should try to see what is the values which you would be getting of peak inspiratory flow rate. Am I right, Raja? You can correct me wherever I go wrong. This I would specially insist on our older patients. Right?
Sure.
And
I've got a question for you. I'll ask you something. You are the most experienced clinicians among all of us on this panel. So I have a question for you. What do you do in real life when you give a patient an inhaler? So I'll tell you my bias. I actually, when I give an inhaler to the patient, if the patient has never been on an inhaler before, I choose the inhaler for them. I don't actually do what is written in the books, which is to tell them, please make a choice. These are the inhalers that are available. Please make a choice. But when they come back to me the next time, I find out how they've done. And then I tell them whether they can continue on it or whether I give them the option of another one. Do you do it the same way, or do you do it actually in the way it's taught by GINA and other global bodies?
Actually, what we do or what I do is young patients who can understand my instructions, one who can follow my instructions, meter dose inhaler is my choice of inhalers for them. A little elderly who may not understand the instructions given and not being followed, they are not willing to spend money at a time. Though DPIs are a little costly than MDIs, they may not be able to spend at the given time. And buying a device is a one-time expenditure. I prescribe dry powder inhaler devices for them. However, it's equally important to see many times I ask them, and this I really do in practice, that I ask them to demonstrate how they are taking their DPI and whether their flow rate is good enough to cause that turbulence. Turbulence is very important. It's important for me because it assures me that it's being taken properly. But it's equally important for the patient because you need to break down those powders into small sized particles to reach to the lower respiratory tract. Otherwise, all this discussion or even a prescription of devices is going to go waste if the drugs are not reaching to the lower respiratory tract. That's what we do. For children, what I have found is that when we discuss, and in fact, we had a wonderful World Asthma Day where we interacted with pediatricians also.
Sure.
And they were a little reluctant even about MDIs. But when I told them that you have to counsel a children like, wo hathi ke soon se le raha hai, and children are very happy. So MDIs with spacer are the best choices for children who are too young to understand anything, and it's the parent who has to advocate the drug delivery to them. And at the extreme end of course, elderlies, it's always best to prescribe with spacer rather than doing any permutation and combinations. Because if you jitna permutation combination karte rahoge, the patient would feel that the doctor is not confident or usko meri nas samajh mein nahi aa rahi. That is what the patient would carry. So I would always say that for elderlies, don't think much. Even if the flow rates are good, it's always good to give MDIs with spacer to them.
Yeah, wonderful pearls of wisdom, Radha Didi. So a lot of what you said is thankfully what I do in my clinical practice, but I've learned a few things there. So I think all of us will take the audience here, go and listen to devices. They'll tell you, give the patient the choice. We are telling you something different. When you're giving an inhaler to a patient, for the very first time, you make the choice for them. It's difficult for patients who have never known about asthma to make a choice at that time, but do keep going back to them and ensuring that they can do what you want them to do. You heard Didi talking about bringing the device and making sure that they can use it the next time around. Get them to do it rather than you showing them what is done is important. Yes, please.
Can I add something?
Sure, of course.
And when you look at how DPI is being used, till today, we always see the DPIs coated with powders as if they have been painted. Yeah. And in spite of telling they don't wash, they don't clean. So I think it helps a lot. Observing, supervising helps a lot.
Sure, absolutely. So wonderful pearls of wisdom. Let me come to you, Ravi. Ravi, you are the best patient educator that I have seen. You know, your videos, I'm a fan of. I keep seeing them on Facebook. So I think this question should go to you. GINA, for the first time in asthma, mind it, in asthma, not in COPD, talks about physical activity. It talks about movement. It talks about exercise in patients with asthma. Now, that's something new. We've talked about it in COPD. We've talked about it in ILD, but never in asthma. So your take on this new change in guidance in 2023, and then a take on how is it that you talk about rehab, exercise in the space of asthma as opposed to other chronic lung diseases where pulmonary rehabilitation is far better established. Ravi.
Sir, thank you, sir. This truly is a very welcome development in the GINA 2023 as far as exercise and physical activity promotion is concerned. The advantage that is quoted in this guideline is it helps in reducing cardiovascular mortality and it increases the fitness. It gives the patient a better quality of life. But at the same time, the guideline very clearly says that this increased physical activity will not help reduce airway inflammation or improve lung function in any way. But since there is an increased quality of life, the guideline very strongly recommends promoting physical activity in patients up to moderate level of asthma. There is some amount of benefit seen in asthma symptom control also, and no significant benefit in lung function with physical activity. If the patient is a non-obese person, high intensity exercise with high protein diet is recommended as a part of his activity. And if the patient is a young individual, a young patient, then swimming has been given as an option in this current GINA guideline. So this is what it recommends, sir. As far as pulmonary rehabilitation in asthma, a bit difficult, sir, because COPD-like conditions are persistent, and the patient and his family can understand why they keep on need to doing something. But asthma being an intermittent disease, maybe only in moderate and severe category asthmatics, the relevance of pulmonary rehabilitation can be reinforced on, sir.
Sure. Ravi, completely agreed. Wonderful points. So just to sort of summarize what you said, carry home message, we're thinking about two categories, Ravi, isn't it? One is a young group of patients, and younger patients should have no limitation of activity, and they should be active, which is not something GINA had spoken about today. Active in whatever they do. If they're running, they should run. If they're swimming, they should swim. And there should be no limitation of activity. The chronic elderly asthmatics probably will behave no different to your patients with COPD who have fixed airflow obstruction. And there the concept of rehab probably need not be very different to what we do in our COPD patients. And I think you're allowed to extrapolate evidence from the COPD category there. So I think that's sort of the gist of what GINA said. But the details, I think it's welcome, like you said, that rehab and exercise has come into the domain of asthma today. Let me come to you again, Dr. Radha Munje. So, Didi, asthma action plan. I mentioned it briefly in my talk. I'll come back to asthma action plan. So, there's a tiny change that they've done in the asthma action plan of 2023. They've said that instead of the SABA, the 10 puffs of SABA into a spacer, you can use 2 puffs of the ICIS for Metrol together when you get a mild exacerbation. So that's how they have tweaked it. So I want to ask you 2 points under that asthma action plan. A, do you have an asthma action plan for every patient of asthma that comes and sees you? That's one question. And the second, how convinced are you that the SABA into a spacer would be as effective as the 2 puffs of formoterol that GINA has spoken about in 2023?
To be very truthful, Raja, I would say that yes, can you hear me? Can you hear me?
I can hear you now, absolutely. Loud and clear. Thank you.
Howsoever, I would like to give asthma action plan to my patients, and even if we have those leaflets and all, I cater to a public sector where most of the patients do not understand it. So what we do is like what earlier few of my colleagues have said, that we let them know what are the symptoms they should be looking at, and we ask them that have they increased the use of their inhalers. That's what I do. So I'm very sorry. I would have loved to comment on this, but had I had my first-hand experience of advocating this.
Sure. So anyone on the panel, I'll come back to this question in a moment, Radha Didi, and I completely appreciate what you said. Anyone else on the panel have a point to make for the question that I'm asking to someone else? Just raise your hand the way I have done there on the emoticon there. So, or just raise your hand like this, whichever. Shivani will tell me that her computer skills are less than brilliant, which I disagree with. But yeah, so just a hand raise would also do. I'll tell you what I do, Radha Didi. For my patients, I do give them an asthma action plan, but I give them a simple asthma action plan. So I'll tell you my asthma action plan, and others on the panel can agree, disagree, modify it for the audience who's listening in. So for me, if my patient has taken, if the patient is on ICIS and a formoterol, and if they've taken 4 or more puffs of rescue on 3 consecutive days, I would ask them to come into hospital. And I would at least get them to see a GP or a physician or myself to come into hospital and get seen. That's number one. The second is if you're coughing, if you're wheezing, and this happens to be the 25-30% of my patients who use a peak flow at home, and the peak flow drops below 50%, I would ask them to start an oral corticosteroid, but come quickly to the hospital. I wouldn't ask them to stay at home and take the oral corticosteroid. I would ask them to come into the hospital, but try and take a steroid early, because there's good evidence to show that the earlier you take the steroid, the greater the chance that you reduce the risk of a life-threatening exacerbation. So that's my second protocol. And the third, like I alluded to, I actually am not completely convinced about using ICS formoterol 2 puffs, one after the other, being of equal effect as 10 puffs of SABA in a spacer as of now. I might change my mind 2 years down the line, but as of today, I'm still happier putting the 10 puffs into a spacer and asking the patient to take inhalations if they have a bad cough, if they're wheezing, if they're breathless, or if their peak flow meter shows a 50% reduction. So those are my action plans, and I give that to everyone. I have a piece of paper, colorful paper, which I hand them over. It's pre-printed from before, but I get my respiratory nurse to sit with them and explain them this plan, which is a slight modification to what GINA does, but I think it works in most of my patients.
But another thing which I learned in this asthma day interaction with pediatricians, and I think that we need to have asthma action plan with different emoticons for children, because children understand everything better. There is no question whether they are educated or not, literate or not. They are very, their responses are very good. They react well, they understand well, and they are happy to communicate also to the doctor, because every time otherwise the parents tell what is happening to the child. But if a child is asked, what do you have, what type of, difficulty you had, did you had an audible wheeze? I think with each emoticons, they would be,
absolutely. I like that.
Very happy to respond.
Yeah.
And that is something which we must work together on, Raja.
Absolutely.
In fact, the whole panel.
Agreed. Absolutely. So, Shivani has proven me right. She's done well with the emoticon. So, Shivani, to you, you had a comment. You've raised your hand.
Yeah, I just have a small comment to make, that when I'm giving my patients who understand, who have that level of understanding, when I'm giving them an action plan, I also always mention that if they're taking the MDI with spacer, in case of an acute exacerbation or they're feeling worse, or when they need their reliever medication, for the MDI, I always tell them not to panic. At least wait for a minute between 2 puffs and not just try and take the puffs one after the other. So, because that can compromise the delivery of the drug. So that's another point that I always try and tell them.
Yeah, that's a great point, Shivani. So the point that Shivani makes, in addition to the advice that we talked about, is very important. So, breathlessness is a very anxiety-provoking symptom, and anxiety is a very breathlessness-provoking symptom. And you get into this vicious cycle of anxiety and breathlessness, which keeps making your breathlessness worse. So the point she makes for all of you out there listening to us is that you need to keep calm when you feel breathless. You need to be counseled. You need to have someone to hold your hand when you're feeling breathless, because the anxiety due to the breathlessness is going to make your breathlessness worse. And you keep taking puffs of salbutamol, which helps you to develop tachycardia. You feel palpitations, you feel more anxious and more breathless. So the counseling part is very well taken, Shivani. Valid point. Quick comment from you, Ravi, before I move to Vinay.
Well, sir, my prescription of asthma, usually the MART part, which is very important, the ICS plus LABA and SOS doses up to 3 to 4 as per your severity. And one very important part is we tend to prescribe nebulizers now more frequently and write it as SOS. So I think that too must be included in your asthma action plan, because nowadays nebulizers are much more handier than I think what GINA prescribes them in its guidelines.
Yeah. Fair point. I'll come to you, Vinay, in a moment. I've got a question for Kripesh first. And Kripesh, I asked you this question because my feeling, I might be wrong, but I think you are the most digital savvy person on this platform today. So I have a question for you. Smart inhalers, digital devices for increasing awareness, do you think they work in India? I mean, GINA has said it's something to look up to. But these smart inhalers, which tell you whether the puff is going in or not, send lots of data into my smartphone telling me whether the patient has used it or not. Frankly speaking, I don't have time to look at that data. Do you? And does it help you in your day-to-day clinical practice?
Actually, I haven't used those smart inhaler. I'm using inhaler that have a counter that at least help the patient to note down it. But but certain things, that digital things that can help the patient to increase adherence is that your dose reminder that have you taken your this medication, or certain things that on a certain time period, or at least use messages or text messages from some attendant or some follow-up can help them. But regarding the smart inhaler, I don't have much experience and no idea actually.
Okay. Anyone on the panel have any experience? I'll tell you my experience in a moment briefly. But anyone on the panel have any experience with these smart inhalers? So all of what Kripesh said, Didi spoke about, Radha Didi spoke about the emotic ones. Kripesh spoke about the Dosi meter. He also spoke about feedback and aid the memoirs when you have messages coming into your mobile to take the inhaler properly. All those are very, very useful. The smart inhalers, however, are about the device telling you whether you're using a proper technique or not. So unless your head is tilted up the right way, unless you have the inhaler held in a proper fashion, unless you've shaken the inhaler before use, the device keeps reminding you. And then you have, once the patient has taken it, there's a message that goes into the daughter's device, which is in the US, and to your device, which tells the doctor and the relative that you have taken the drug, the patient has taken the drug properly or not properly. And to be honest, I'm sorry I'm using these words. I think it's a pain in the backside, because then you get WhatsApp messages and telephone calls and emails telling you, my mom has not taken my inhaler at night properly. I'm in the US. Can you please help her? So I think we need to find a way in which there's an interposition, someone else who looks at this and tells them, hey, you need to take your inhaler properly. That's the mistake you're making. And then smart devices would become more useful in our country. But I think digital devices, digital advances, AI, all of these are very welcome. We just need to know the way to utilize them properly going forward. Still in the domain where people are trying, and going forward, we will probably have some idea as to how to use these. Okay, let me come to you, Vinay. Vinay, I've got a question for you. There's something very interesting which I came across when I was reading through the GINA guidance this time. It talks about the FDA in the US talking about recording oxygen saturations in dark-skinned individuals, which includes us, myself, I guess. So any thoughts about this, about measuring pulse oximeter saturations in dark-skinned people? Do you think it'll have an implication? I mean, I read it for the first time when I read through GINA this time. But do you think it'll have an implication for us? What are your thoughts, Vinay?
Yes, sir, it does, because we assume that the light is absorbed by hemoglobin only. So, but especially in the dark skin individuals, the interference is the pigmented part. It also makes difference in recording saturations. Thereby, it overestimates the saturations, especially patients who are in respiratory failure. We assume they are otherwise normal, or sometimes it guides. Suppose many times during discharges and during follow-up visits, at outpatients, we largely depend on saturation only, pulse oximeter only. So here we should have a clear-cut knowledge, especially dark skin individuals. As we know, especially people with nail paints and thick skin, rough skin individuals, we do confirm by clinical means, by ABJ means, otherwise. So, and this time FDA has clearly issued notice, especially in dark individuals, we should have a labeling. And I think they are coming up with some guidelines. So it's an important point everyone has to consider.
It's got huge implications though, Vinay. I mean, very fair points. So if you're saying that dark-skinned individuals, I mean, we are fairer than our African colleagues, for instance, but if you're saying dark-skinned individuals have a higher saturation recorded, I mean, not having a high saturation themselves, but a recording of a higher saturation.
What estimation?
We have our guidelines based on a 94% cutoff for COVID or an 88 to 92% for your patients with COPD. All of that needs to be modified by a correction factor, like we've done for our FEV1 in spirometry today, for instance. You know, so there will be a correction factor that comes in. And if there's a significant difference, I don't know what the difference is like, but if there's a significant difference, it has got huge implications in all our clinical practices. And that's one space I think we need to watch out for when the next GINA or the next paper comes out on this going forward. So that's something important for us to remember. Thanks, Vinay. So let me come to the next very interesting section, Shivani, the section which talks about the environmental impact of inhalers. So what do you think about environment impact? So till now, like I said in my talk, we keep thinking about what inhaler is right for our patient, what is it that they'll comply with, what sort of drug is available in a particular inhaled device, etc. We have not really thought about our devices. We've talked about the HFA and being more environmental friendly for the ozone layer, etc. But this is the first time GINA has talked about environmental friendly inhalers. So your thoughts, Shivani, is that something that you've thought about when you prescribed your inhalers? I'll put my hand up. I have never thought about it. So let me find out whether Shivani is better or not. Shivani.
I don't think we think about that, at a spinal level, or that's something that crosses our mind. But however, I think the pharma industry did think about it at some point. So we moved from CFC to HFC at some point, It was, of course, an environmental friendly move because CFC was, contributing in the depleting the ozone. However, HFC is probably contributing in the global warming. So I don't know one way or the other which one is better. Maybe I'm not really well equipped to answer that. And it's not something that comes to our mind. But actually, when I was going through GINA and then that got me interested, and I was reading that, 100 puffs of something like a MDI or a breath extenuated device, actually the carbon footprint it's huge. It's equivalent to driving a small car for 290 kilometers. So, the carbon footprint that the inhalers leave is actually massive. And we don't even give it a second thought when we are prescribing it to a patient, which is, like so many times in the entire day that we do it. So I think that's something that we really need to look into, because the carbon footprint here is massive, and environment is something today that we must be really, really bothered about.
Yeah. So Shivani, very fair points you make. So I'll just enlist them. You spoke about the ozone layer. You spoke about the carbon footprint. You spoke about global warming in a way. And you spoke about the fact that HFA seems better in some ways to the CFC. The one point I want to add, which I think we also need to speak about, we wrote a white paper in Lung India last year with my good friend, Dr. Arjun from Cochin, which is about the disposal of these inhalers. All of this is plastic, So the MDI is plastic, the DPI is plastic. We never tell our patients, well, I'll put my hand up and say before last year, when we wrote up this white paper, thanks to Arjun, he pointed it out to me. I have never thought about how I ask my patient to dispose this plastic. So that's another environment friendly or unfriendly move that we need to think about. I can see Radha Didi's hand up. So Didi, your wisdom. Tell us whether you've done it, think about it. What do you do in your practice?
I haven't done it, but I'm sure I read somewhere that the pharmacist was collecting empty canisters. It's not only about the plastic, but the remaining, HFA in those canisters lying there. And that rat cookers would break the canisters to collect the aluminium from that, because they are of aluminium. So I think, adds a lot to pollution. And perhaps next time when Raja asks me the question, which device would you select? Probably I will leave the canisters and go to the plastic bottles, because most of my patients, even if I ask them to change the DPI device, they would not change it. So even if it's bad for the patient, because the inner side gets, eroded and all, I'm rather scratched, but that's one point which we must remember when we prescribe.
Absolutely. So from the CCI platform today, I don't know how many people are logged in, but there's normally more than 1,000 people logged in. So my fervent request, our fervent request from this platform, when you're prescribing your inhalers, talk to your patients about disposing them off and how to dispose them off when your inhaler becomes finished. That's something important. I put my hand up. I said I didn't do it before. Last year, I do now. But please do it. Please make sure you think about disposal of inhalers. Think about the carbon footprints that Shivani so eloquently spoke about and the global warming that it entails. Okay. So another interesting question. I'll start off with Vinay this time. Vinay, GINA interestingly talks about the less affluent countries, as they call themselves, or the developing countries, and talks about the lack of inhaled medication in those countries. Lack of proper inhalers, the formoterol, budesonide. I don't know which countries don't have it, but they talk about lack of these inhalers. I feel our country has gone the reverse way. I think we have got too many combinations, too many inhalers, too many devices, and it's actually often quite confusing as to what you use and what you don't use. And you see, from a GINA perspective, the good thing is that we've got one inhaler and one combination. The bad thing is that we've got plenty available combinations, but we have one inhaler and one combination. What do we do with the remaining 19? So there's a lack of positioning of other inhalers, which could be a challenge. So a comment from you first, Vinay, and then Radha Didi, about how you go about positioning inhalers other than formoterol budesonide in your clinical practice. What happens to the remaining combinations in asthma?
It's a difficult question for me, because my choice is always formoterol budesonide. But sometimes patients who are already on some other medication or who are already using some sort of medicine from other consultant or carrying their medicines. So quite obviously, we have to see ultimately the basic fundamental thing is ICS and LABA. So, and if I are sticking to ICS, LABA, and as well as if it is like reliever as well as maintenance model, that's good enough. So whatever they are carrying. So not only that, so main things, whatever the combination they are using, ultimately we have to look at the local factors, availability and affordability point of view. And next thing is the technique, whether they are using proper technique or not. And ultimately, as we are discussing the environmental impact. So if they are satisfying these things, I think anything is okay.
Yeah. So Vinay bhai, you are a formoterol of your patients and happy with it. If your patient is stable, other inhaler combination of ICS LABA, you're happy to keep them on it. You don't change it, is what you said from my understanding, which I completely agree with. Let's see whether Radha Didi has any different take, any other combinations that you use. Dr. Radha.
I do prefer to, if I have to prescribe the patient, I prefer to prescribe ICS with LABA, which has a budesonide formoterol combination. But when I have to procure those drugs in my hospital, and when the cost factor comes, sometimes I do prefer to buy fluticasone, formoterol fluticasone rather than budesonide, because it is a little bit higher, if I'm not wrong. And the third thing is, if I don't purchase, but if it's already available in the stores, that is the first choice of my prescription. Then it may be any combination, and I have to explain to the patient what I'm giving him free, and what I would like to prescribe him is a little different. But if he's not going to buy, then I would dispense with whatever I have. That's my take.
Fair enough. So you said things which are more or less similar to what Vinay said, which is your choice is formoterol budesonide, but depending on what's available in the public, you might prescribe other inhalers, telling them that there are better combinations available outside, which you might prescribe if they're happy to go and buy for better control of their asthma. So completely well taken. I've got some points to add to this, but I'll do it in the perspective of the next question that I'll ask Dr. Ravi Dosi. So Ravi, there's such a lot of talks. I mean, I think I did a talk a few days ago on the Ultra LABA ICS in your city a little while ago. And there's good data. I mean, you cannot do away with the data which comes out in the New England Journal or Lancet about the vilanterol fluticasone or the indacaterol mometasone, which are available from various companies today. However, again, there's hardly a mention of these drugs in GINA. There's fine print this time. If you read through, there's a fine print of Ultra LABA and ICS. But tell me your thoughts. Do you think we have not reached the stage when these drugs should be used, can be used in our patients with asthma? Or do you think we are missing a trick when we are not prescribing these evidence-based drugs in our patients with asthma today? Ravi.
Well, sir, as far as this time's GINA 2023 mention of Ultra LABAs, in step 5, they have mentioned vilanterol in the triple drug combination, where they have told that you can go ahead and use it if nothing else is working. But I think with a very good reference, which I dedicated to you only in 2022, you have published in Advanced Respiratory Diseases on Ultra LABA in obstructive airway diseases in India. I think a very relevant point which was raised, that people who are having poor symptomatic control, ultimately they will benefit if they get a inhaler which is having more lipophilicity, more receptor binding, stronger potency. single time administration will increase the adherence to that particular inhaler also, and the patients will hardly be having to use any reliever medication in the form of SABA. So these are some of the benefits which LABAs, ultra LABAs can offer to our step 5 GINA asthmatic patients.
Sure. So Ravi, fair point. So I think there's at least in my practice, I'll tell you, I'm a firm believer that Ultra LABA and ICS is either of the two combinations available in the country today maintain the greatest degree of stability for your asthma. So if your patient has stable disease in step 3, for instance, and the patient wants to go from a twice-a-day combination to a once-a-day combination, I would discuss the pros and cons with them and shift them to once a day. And I think any inhaler in stable disease can be used in step 3, 4, 5. It doesn't have to be for methyl budesonide. There's a space for all combinations as long as your disease is stable. As the problem with the Ultra LABA ICS today is, what do you use as the reliever?
Yeah.
So your maintenance therapy is fine. You're giving them Ultra LABA ICS. What happens to maintenance? And there's a nice little paper. This was the paper I was talking about, Ravi, just now, which looks at the ICS SABA as rescue. And we spoke about Aerocort a little while ago. And I mean, that's an inhaler we've had for 25 years. And we've spent time saying, I have spent time saying that this is a bakwas inhaler, which is not worth it. And I have been proven wrong and badly wrong over a period of time. But I'm happy that we have this inhaler. So you can maybe start using an ICS. So there's a budesonide salbutamol inhaler that's going to come to India, one company or two different companies which is going to bring it. And that's probably going to be your rescue now. So for 3, 4, 5, there is space for other inhalers. But as of now, you're probably going to have to use the salbutamol for rescue. And if you're using too much salbutamol, you need to shift to formoterol budesonide. But that's my thinking, that the space for everything, but it's in stable disease, not when you're needing a lot of rescue, because there's no evidence about the rescue. Ravi, I had a question about pediatric asthma, but rather than asking you 2 questions, one after the other, let me first go to Kripesh, and I'll come back to you later. So Kripesh, I wanted to ask you, with the emerging evidence of the increased morbidity with SABA, do you think we should actually go out and talk to our physician colleagues about reducing the use of SABA? Tell me some strategies. So I know you do a lot of public teaching up in the Northeast, all over the North.
Yes,
what do you do
definitely.
to reach people?
There are, yes, there are. I feel there are 2 ways we can reach out to our physician, by talking with them and doing some CMEs in-house or in different peripheries, and also changing our own practice. When they will see that our practice of MART therapy and we are not using SABA, this will have an impact on them. So this is how we can work on reaching our physician colleagues.
Sure. So reaching out to them, talking to them, doing webinars like we are doing today, going out, speaking to them. Vinay, you are from a different part of the country. Let me ask you, any other thoughts? How do we actually tell people? I know you have told us that you're a big fan of the MART therapy. That's what you do in all your patients. How do you get others to do the same as you do in your practice?
Because it is working. And it is simple. Because not only as a maintenance therapy, as a reliever rescue medication, because many a times patients, once they are stabilized, they forget about their symptoms. They tend to discontinue that therapy. Once again, they're symptomatic, then only they start using medication. Here, the beauty with this combination is helps as a rescue medication as well. So that is the reason
Sure. No, Vinay, we are sold on the idea. We are convinced. What I'm asking is, physicians, GPs, how do you reach out to them in a teaching, mentoring capacity and tell people, this is what I use, you do the same? How do you go about doing that?
Yeah, of course, by doing programs, as you said, by reaching them, by talking to them, by talking to them.
Programs, modules, guidelines, right? Yeah, absolutely. Grand.
I also...
Ravi, a quick line from... Yeah, sorry. Go on, Kripesh, please.
Yeah, I also whenever I take a round nowadays, whenever I meet my physician colleague, I update them that this is a new guideline has come and these are the strategies where I talk about anti-inflammatory reliever therapy to them. So this will gradually propagate to the physician group and then down to their D&D students. So again, practice may have some impact.
Sure. Great points, Kripesh. I think it's important. I mean, there's so many people on this platform today. It's not enough for all of you out in the audience to just do it yourself. It's your responsibility to talk about anti-inflammatory reliever therapy the way all of us have done, Kripesh has just done. Do it for the people you meet, the teachings that you do. Make sure you have a slide which emphasizes no inhaled therapy should not have an inhaled corticosteroid in it in the area of asthma. I think that's an important message from all of us. Ravi, short comment. Got about 10 minutes before we finish. Got some lovely questions from the audience. And apparently, guys, got more than 2,000 logins here, Kira tells me. So that's brilliant. 2123 logins. Very impressed. So, Ravi, tell me something. Pediatric asthma, for the first time, they've mentioned maintenance and reliever therapy in the area of pediatric asthma. So tell me your thoughts briefly and whether it's something that would translate into your clinical practice in the children that you see on a day-to-day basis.
Definitely, sir. What GINA tells this time is something that we have been doing practically in children who are 6 years and younger. Still, it is track 2 management, like we were told initially. It is predominantly SABA use with MDI and spacer use, which is recommended in stable asthmatics up to the level of till they are, let's say, step 3. Then in children who are age 6 years and above, there is the recommendation of MARD therapy in which they recommend ICS with LABA combination. Initially, we should start with low dose ICS SABA, and then as per the severity and symptom control, if needed, we progress to high dose ICS and LABA. Accordingly, patients of the 6 to 11 age group are managed with the MARD therapy almost like adults only, but the less than 6 group will be managed with SABA. The very important thing is now we have an official recommendation of using inhaled steroids in children, because there is a very big taboo of using inhalers, number 1, and number 2, giving inhaled steroids, because most, like you told, sir, more than physicians, pediatricians need huge awareness. It is as if they need a re-education only about inhaled corticosteroids, because they will, the moment the person comes from your clinic to the pediatrician, which they do, अरे इसका growth रुक जाएगा, bone growth में problem आता है, गला खराब हो जाएगा, आवाज बिगड़ जाएगी, उसके दांत टेढ़े मेढ़े हो जाएंगे. That is a very, very common thing which characteristically the mother or the father will call you back in a not so friendly voice over the next 2-3 days. So I am thankful to GINA for including ICS officially in this pediatric asthma guideline.
Yeah, wonderful comments, Ravi. All very valid. I am very happy to prescribe ICS LABA in my patients with asthma. However, having said that, other side of the coin, small caution. The reason GINA has not included it in the less than 6 category is because of the question of overuse of the ICS. And if we end up having ICS plus SABA, the chances of overuse are greater. So I'm completely with Ravi in what he said about use, especially in children between 6 to 11. However, with the small provision that if you're needing increased doses for reliever with an ICS and LABA, please go back to your pediatrician or pulmonologist and tell them that you're needing it, because with large doses, the question of growth retardation does come in. So it's only with large doses, not with small or medium doses, but it's worth remembering. Radha Didi, quick comment.
Yes. I just wanted to add one thing, that all our pediatrician colleagues, they're all friends and colleagues. The first thing which should go out before we talk about the prescriptions and the treatment is, do not hesitate to label it as asthma, rather than giving different names of asthmatic bronchitis and this and that, whatever. They should be a little, I won't say bold, but should be proactive. We have interacted, and as Ravi said, that they go back and talk to the pediatricians. But when we interact with pediatricians, what they say is that no sooner do you label that the child has asthma, half of the parents are not willing to accept it as a diagnosis. So first and foremost, I would always say that label the diagnosis and do not fear of the taboo or whatever the parents would come up with. That is one thing. And then only it would change their prescription pattern. Another thing I would say is that they usually, because for, children-friendly formulations are available. So rather than giving inhalers, they would also go for syrup, terbutaline, and whatever are the other things which are available. So I would always say that a proper counseling, giving a good device, explaining would go in a long way in managing pediatric asthma problem.
Yeah, wonderful, wonderful comments, Radha Devi. Absolutely. So call a spade, call asthma. Don't give them names like acute bronchitis, wheezing cough, and so on. Call a spade is what Radha Devi is saying, which is a very valid comment. Quick comments, quick answers I'll come to you, Shivani, first. Exhale nitric oxide. Do you use it? And what are your thoughts about what they have said about children and pheno still not being useful in children for the management of asthma? So, two comments. First, do you use pheno in asthma? Second, do you think the guidance is going to change your use of pheno if you use it in your asthmatic patients?
So again, pheno is something which has come up really in the recent years for the use of asthma, and especially also predicting an exacerbation to look at the level of inflammation, since it's come out as a great predictor for at least type 2 inflammation. I don't really see a lot of children, however, in my practice. And what GINA recommends is, of course, that it's a great positive predictor for, inflammation. But however, in children, there are a lot of other conditions where it can be falsely high, especially children who are atopic or children who've had a recent viral infection. It can be falsely high. So even though it is a great positive predictor, we must look at the clinical picture. And even then, it can help in predicting the asthma risk in a later life, or also maybe in children who are known asthmatics, maybe to titrate the dose of ICS. The advantage of pheno, of course, remains that it is easy to perform even for kids.
Sure. So great comments. So pheno for me is a marker for Th2 inflammation in adults. And it's good when you have a raised pheno in someone you think has asthma, but has a normal spirometry. I would use it there. I think a low pheno is a good predictor on stepping down doses of inhaled corticosteroids. And if someone claims compliance and you find a sky-high pheno, I would think the patient is lying and they are actually non-compliant with medication. That's where I place pheno in my practice, as you said, Shivani. And in children, there's emerging evidence, but we're still waiting. Pheno will be useful in children too, but we don't know exactly how it is, like you said. Important carry-home messages from GINA. When I'm asking you this question, maybe I should answer this question myself, because I live in the most polluted city out of all the people on this panel in Kolkata. But I'll ask you this question. Pollution, do you think it's important? Do you think it's something that we need to think about when we think about management of our patients with asthma? And if we do, tell our audience in what way should they think about asthma as being a trigger for asthma, and what should they do?
Yeah, sir, there have been a number of studies. Clearly, these epidemiological studies and meta-analysis have proven without any doubt. So there is a clear-cut relationship between the exposures, whether it is indoor pollution or outdoor pollution, with the exacerbations that was clearly documented. In fact, recently these digital monitoring have identified these exposures to the time lag between the exposure to the increased symptoms or increased medication use. About 3 days, 0 to 3 days has been registered. So as we know, the universal precautions, where we have been talking all these days, like reducing the indoor pollution, like using the cooking devices, will have less polluted and heating devices, and should have a proper ventilation, vent outs, And in addition to that, especially regarding outdoor pollution, and there are clear patients whose symptoms are well controlled, of course, they need not to bother, but who are having repeated exacerbation, they have to be very careful in moving out, especially in high pollution times or viral infection seasons. These things one to mind, take care. These are universal precautions. In fact, GINA has recommended and able to everyone wherever they are.
Yeah. Do you think wearing a mask is relevant in this scenario? I'll come to you, Radha, in a moment. I've seen you and I'll just come to you. But Vinay, any thoughts about the mask? Do you think that's...
Definitely, sir. Definitely, it has proven beyond doubt. Mask is definitely helping a lot in reducing the number of exposures and preventing exacerbations.
Sure. Especially the viral triggers. You know, the viral triggers of asthma causing exacerbation. You could probably keep them away by wearing the mask. It's uncomfortable. I don't like wearing them myself. So I'm not the person to preach, but it does help, like you said. Quick comment, Radha. We've got about 3-4 minutes. So quick comment.
I just wanted to add to what Dr. Vinay Kumar was saying. Being a superintendent, I happen to go to many of the meetings which are taken at a district level. And what I have known surprisingly that the pollution index or the contents or whatever are predictors of pollution, they are being marked every day. And they wanted to have a mechanism in place where it can be correlated with number of cases reporting with allergic symptoms, whether rhinitis, cough, or wheeze or whatever. So what I think that from this platform, Raja, you can appeal that जैसा temperature predict रहता है, predicted रहता है. Similarly, if we can have some predictions that for a particular city, the pollution level is beyond this, and we expect more number of cases, this. So we would have a good record and data to which we can refer over the years.
Yeah. So Radha, my only fear is that the state I live in closes their schools and offices at the drop of a hat. So if you have a recording of air pollution on a daily basis, our schools and offices will get closed even more frequently. But I take your point completely. I think maintaining data and keeping it is very, very relevant. Quick comment, Vinay Bhai, we're really running out of time.
In fact, what Radha Madam is telling, that's true.
Yeah.
In fact, even the recent GINA guidelines, they have mentioned in the Beijing Olympics in 2008, with the traffic restrictions, there is a clear-cut decrease in number of observations. They have documented it. They have clearly mentioned this thing. So this is
absolutely. So I'll come to you, Kripesh, with almost a semi-final question, and then I'll come to the entire panel and we'll take a few questions from the audience. Kripesh, a question about role of formoterol or formoterol budesonide in the emergency department. You know, when our patients come to the emergency, your emergency, my emergency, we normally would nebulize them with a duolin or a levolin or some sort of a short-acting beta-agonist, Sarmah, etc. Do you think with all the data that we have today, it's time to start nebulizing them with the formoterol budesonide or giving them an inhaled formoterol budesonide? Or do you think we don't have enough data to start doing that? Or have you started doing it already?
There is a certain amount of data that support using of inhaled formoterol budesonide. So not all, but some patients we have tried it, but majority patient we still use the same SABA and ICS combination. Is majority of the patient are being still treated in emergency.
So Kripesh, clear message for our audience. What should they do? Stick to the levosalbutamol ipratropium combination, or should they go to a formoterol budesonide combination, or maybe do it on a case-based basis?
I think there should be a case-to-case basis.
Okay, so I'll push you a little bit more. So case-to-case basis, which case would have a formoterol budesonide and which case would have a levosalbutamol?
Yes, those patients who are using MART therapy, who are still using this formoterol budesonide combination, they are the ideal candidate to continue the same medication in their emergency. And those who are using other combination, or there are several combinations where I think we can use still the salbutamol and the budesonide combination in emergency basis.
Wonderful answer. Thank you. So let me quickly come. Radha, you got your hand up. Is there anything you wanted to add, or can I come to my... Okay.
No.
All right.
Sorry.
Okay. So that's from before. No problem. So let me start off with Shivani. Shivani, I've got a question for all the panelists. I'll take audience questions after your messages. So we've gone through the GINA guidelines today, and I think since 2019 till 2023, there's a lot of changes in GINA. So think about the entire spectrum of changes. What do you think is the most relevant change in your practice, my practice in India? So one change, and what message you want to give out to the audience based on the 2023 guidance, which is stuck you the most and maybe made a change in your clinical practice day to day. Start off with Shivani.
Okay, so I think the biggest change that has come over in my practice over the years is the smart therapy, that I have gone on to, adapting one inhaler for reliever as well as maintenance, apart from other things. So I think that's the most important message that I would want to give.
And the audience takes home the message: no salbutamol, use smart therapy for metronidazole budesonide for most of your patients. Right, Shivani? Grand. Let me come to Kripesh, your one message which stands out in an Indian perspective, GINA 2023, and sort of between 19 to 23, what stands out most for you? Kripesh, you're on mute.
Can you repeat the question? Your voice is not clear.
I said, I'm so sorry. I said, what is one message that you want to give the audience about the changes in 2023 GINA and Indian perspective? What is it that you think has made an impact in your practice, which you'd want to tell the audience as a carry home message from your side?
Yeah, for Indian perspective, the most important message from the GINA is again the same thing almost. That is that we have to rely more on the inhaled corticosteroid rather than this bronchodilator alone itself. Because in India, we use more bronchodilator, particularly in periphery, and there is a very little inhaled corticosteroid use. If you see the data of use of inhaled corticosteroid inhaler in India, it's quite less than actually it should have been used. So that's why we should focus mostly, the audience should focus mostly on this inhaled corticosteroid or anti-inflammatory therapy, which is now the main cornerstone of and major changes that has been recommended in GINA guideline.
Sure. So no inhaler should not have an ICS in it is what Kripesh's message is, which is in line with what Shivani said. Vinay bhai, your message.
Sir, stop using orals and catch up with the inhalers. That is only.
Inhalers, but not salbutamol.
Yes, sir.
Don't know if it's connectivity, but I have frozen.
I think you asked for my take-home message, sir. My point is that this GINA guideline should act as a clear-cut recommendation even to the authorities that if any doctor is diagnosing asthma, then inhalational therapy should be made mandatory, and slowly these government supply and public supply of salbutamol, which is so easily available, should really be withdrawn from the market as soon as possible.
Wonderful. So all strong messages. Let me come to the final one from Dr. Radha. Radha Didi.
Yes. I think GINA has, this GINA 23 has given us 3-4 good things. The important one, which each of my colleagues have underlined, that is the drug and the device. That has already been underlined. But it's important for us to understand that even the exercise has been emphasized on, and the long term, what really as a doctor and a citizen you should look into is environmental pollution or the effect on environment which the devices would have. So it's always choose wisely. And I may add that each doctor should help their patients to identify their triggers and stay away for exacerbation so that you decrease the use of drugs automatically.
Yeah. Grand. I think it's my connectivity which is a challenge actually more than anyone else's. So very quickly, before we finish, can you guys hear me? First question, can you hear me? Am I audible to you?
You are audible, but Raja, it would be better if you switch off the video and the voice would be much clearer. Just try it once.
Let me do that. That's a good idea. Let me do that. Is it better audible now?
Yes.
Yes.
Okay. Okay. So very, very.
Voice is breaking. Raja, you have to just put off the screen. Log out again.
I think he's going to log in from another device or something.
You would log in.
Ravi sir, you want to take audience questions by then?
Yeah, why not? Why not? There is a question from Mahendra Singh Raghuvanshi that is asthma curable? So I don't think GINA is giving any recommendation officially on the curability of asthma, but maybe Vinay Kumar sir, any comment on that? Is asthma curable?
It's controllable.
Right. So GINA 2023 also.
Clearly tell the patient, we should false promises to the patient, but we can manage it comfortably without any hindrance to their lifestyle, provided if they're into their basic treatment and basic precautions, whatever we are advising them. It is very well controllable disease, can be manageable like any other chronic disease like hypertension and diabetes.
Right. Right. And like we emphasize that we need to spread more awareness about the correct use of treatment now. And one more question from Dr. Jayaraman from Tamil Nadu is clinically how to differentiate chronic HP and asthma without a CT. So any takers for the question? Raja sir is there. Best person to answer this.
So I'm very sorry. So I don't know what happened to my connectivity. What question are we on, Ravi, then?
We are on the second question. How to differentiate chronic HP and asthma without a CT?
Yeah, so that's a great question. I thought that was the most fascinating question in the question box, actually. So, you know, now that disease which are central, interstitial lung disease which is central, like chronic HP, like sarcoid, for instance, are diseases of the small airways. The small airway disease spills over into the parenchyma and results in interstitial fibrosis. Whereas diseases like asbestosis, IPF, etc., are more subpleural diseases and hence are away from the small airways. So that's why in chronic HP, when you listen to their chest, you hear the squeaks and you hear stuff which sounds like rhonchi. How do you distinguish? I think you do it from history. And once you've done the history, if it
sir, the voice is still breaking up very much, sir.
Voice.
Yeah, voice is still
muted.
Now you are visible, I feel, sir. If you could just complete your point after history, what you were trying to say, sir.
Yeah, so what I said was, once you've taken a history, and if there's clarity that this could be an interstitial lung disease, you CT scan done. The squeaks are different to the rhonchi, but I think the understanding that interstitial lung disease, when it's centripetal, when it's central, can actually be a small airways disease like the small airways disease in asthma. Something we'll find out more with things like oscillometry, which will give us evidence going forward. But it's an interesting area. Maybe going forward, diseases like sarcoid, chronic HP will be treated with inhalers, the small particle inhalers, rather than the steroids that we keep thinking about. So food for thought going forward. Ravi, I was disconnected, so I don't have the questions anymore. So maybe if you go through the remaining 2 questions quickly, sure. And then we can call it a day.
There is a question on, do ICA, inhaled corticosteroid, cause premature cataract on chronic use? So, Shivani, would you like to answer this? Unmute.
The only way that inhaled corticosteroids on a long term would probably cause cataract is when you're giving long-term nebulizations, which probably is not a recommended practice, definitely. So I think if we're giving only inhaled corticosteroids in terms of MDIs or DPIs or breath attenuated devices in any form, I don't think that would ever cause premature cataract.
So I'll add to that, Shivani, in humor. I agree.
Dose different.
The other thing I add in humor is, if you don't give inhaled corticosteroids, the only way you cause cataract is by giving them oral steroids as rescue, and you add to the burden and risk of causing cataract. So it's better to give inhaled steroids even to avoid cataract.
And it's better to let everybody know that it's even dose dependent. It's not only the duration, but the high dose ICS, if used, would result in all the side effects.
Right.
And I would also like to add that the burden of disease and the mortality is actually so high if you're not using inhaled corticosteroids that they'll probably not even reach the stage of having cataract.
That's wonderful.
The final question from Achal Singh from UP, Varanasi, is he wants a comment on a comparison in between a synchronized inhaler or a breath actuated inhaler as compared to as a inhaler with a spacer. So any comments on that, please?
So I think we spoke at length about this. Dr. Radha Munje spoke about the device very, very lucidly. I think the breath actuated device is a great device. It's somewhere between a DPI and an MDI, which makes it brilliant. You know, the synchronization doesn't have to be as much as an MDI, and you're still sort of taking the inhaler, taking the drug with a smaller inspiratory flow, which makes it ideal. So I am a great fan of the breath actuated devices. And I think they're here to stay. They have a large place in my practice, and a lot of people on this platform who also have the SynchroBreathe device as a part of their practice. And I think it's a great device.
Right. So questions are done, sir.
Thank you so much. So thank you from all of you. We were at take home messages. You heard all the messages. I have nothing else to add to the messages given. So to all of you, so to Kripesh, Vinay, Shivani, Ravi, and Radha Didi, thank you very much from the bottom of my heart. The 2,200 odd audience which logged in today, thank you for listening to us and being patient. We've run over time by 20 minutes, but I hope it was worth your while. And I thank you to Krishna Bhai for thinking of all these webinars and taking them forward, and to Cipla for supporting us. Thank you so much.
Thank you.
Thank you, panelists, and of course, CCI, the family of CCI.
Thank you.
Thank you.
And hello, Dr. Vinay Kumar. We were so busy talking to each other, and he was listening very quietly.
Thank you, ma'am. Thank you.
Thank you.
Thank you. Good night.